Tantor Audio, a division of Recorded Books, presents Mama Might Be Better Off Dead: The Failure of Healthcare in Urban America by Laurie Kaye Abraham. Foreword by David A. Ansel, M.D. Narrated by Lisa Reneé Pitts. Foreword. Laurie Abraham's account of the obstacles faced by the Baines family as they navigate the fractured healthcare system on Chicago's West Side is as searing, poignant, and distressing today as it was when Mama Might Be Better Off Dead was first published in 1993. It is particularly painful for me to read because I worked for a decade, from 1995 to 2005, at Mount Sinai Hospital in North Lawndale, the setting for many of the Baines' difficulties. The descriptions of that hospital struggles in the face of overwhelming poverty and despair still reverberate. Many of the doctors and hospital staff mentioned in Mama Might Be Better Off Dead were colleagues and friends of mine. Some have died, some have retired, others have moved on. Yet the real-life drama of the failure of healthcare in urban America, one that is experienced by the Mount Sinai hospitals and in the North Lawndale neighborhoods across America, is as perilous as ever. Mama interweaves three tightly connected and disturbing tales. The first is the story of how intergenerational chronic illness ensnares Jackie Baines and her relatives, her 40-year-old husband, Robert Baines, her grandmother, Cora Jackson, her father, Tommy Markham, and her three children all become caught in the maelstrom of a dysfunctional and incomprehensible sick care system. When we meet them, Cora's right leg has been amputated after poor treatment for her diabetes. Her other foot is now showing signs of infection. Tommy suffered a stroke in his 40s due to uncontrolled high blood pressure. Robert has kidney failure and frequently awakens before dawn to travel to a dialysis center, since home dialysis is beyond the family's means. Both Robert and Cora have Medicare and Medicaid insurance, yet the grinding poverty of their daily lives, the Byzantine insurance rules that allow payment only for acute and long-term care but exclude prevention and basic supplies, and the inadequacy of the health safety net in their neighborhood all conspire against them ever getting well. The second story is about the physicians, nurses, and institutions that serve the poor in the family's neighborhood of North Lawndale. The overworked and harried physicians who care for Cora often provide incomplete and cursory medical care. The emergency room at Sinai is chaotic and overcrowded, not only with victims of violent trauma, but also with patients who still prefer it to a doctor's office, where waits for appointments can be even longer. Before Cora came to Sinai, she was failed by her doctors as her diabetes worsened. One of her long-term doctors was not credentialed in any medical specialty and had failed a state quality board review for overprescribing narcotics and poor documentation. Cora's other doctors work at private practices in wealthier neighborhoods most of the week. This means she often sees unfamiliar doctors when she goes to appointments in Lawndale. Cora's care is fragmented, with an absence of meaningful long-term relationships and no sense of partnership with her many doctors. Jackie, Cora, and the doctors are like ships passing in the night. Cora suffers needlessly as a result. Mount Sinai Hospital, a hospital that has dedicated itself to serving the poor and uninsured of Lawndale, is recognized and respected as a hospital that has committed itself to its community. In Mama, the former chief of the Illinois State Department of Health praises Mount Sinai as a hospital that stuck with the community and slugged it out. But caring exclusively for the area's poor Black and Mexican population has led to chronic financial stress, layoffs, and service cuts. While the doctors do their best, they are overworked, victims of the fractured system that bedevils their patients. Unlike other hospitals that cut unprofitable trauma services and costly high-risk maternity care, Sinai kept theirs open because of high neighborhood need. Given the challenges of healthcare financing for the poor, the story of Mount Sinai's dogged persistence as a community resource is nothing short of miraculous. 25 years later, it remains one of the most uplifting aspects of the book. Mount Sinai is still a beacon of hope for Lawndale and for the nation. The third strand here is the story of the flawed and convoluted spiderweb of Medicaid and Medicare programs, a system that punishes both patients and hospitals. The insurance plans these patients can afford include befuddling copays and don't cover many essential services. Hospitals like Mount Sinai that care for people who are or underinsured operate in a state of continuous financial distress. They lack capital with which to update technology and facilities or attract specialists. Abraham's analysis of the maze of rules and regulations governing healthcare reimbursement for the poor in America may not be as accurate now as it was in 1993. But while many of the details about health coverage have changed, her description of an incomprehensible, unnavigable system still rings true today. By underfunding medical and preventative care, the multi-payer insurance system, including Medicare and Medicaid, continues to fail patients, hospitals, and doctors. Mama might be better off dead remains relevant. The problems of health care access, coverage, and cost described by Abraham are unresolved and divisive national issues, despite the passage of the Affordable Care Act and its expansion of health care coverage in some parts of the country, including Chicago. While more people now have access to Medicaid and private health insurance, the current system has been designed to profit health insurance and pharmaceutical conglomerates, rather than to benefit the underserved or the hospitals that treat them. Even with more people covered, the public and private systems of health insurance are as flawed in 2018 as they were in 1990. Sinai and the patients in Lawndale still suffer. Meanwhile, the community of North Lawndale, like many similar neighborhoods across the United States, continues to be a neighborhood characterized by concentrated poverty, economic hardship, and segregation. Little has changed, though there are occasional bright spots. Lawndale Christian Health Center has grown from a storefront clinic to a booming community health complex, with a healthy restaurant and an exercise center just down the street from Mount Sinai. The opening of a farm and a hatchery provides needed jobs and fresh food. Local organizations are active in community building. Sinai Health System, like other safety net hospitals in poor urban and rural neighborhoods throughout the country, nevertheless still faces an ongoing existential crisis of underfunding. The hospital also struggles with the social and structural conditions their patients experience, the causes of premature mortality in North Lawndale, including heart disease, cancer, hypertension, and homicide, have changed little since the early 1990s. Life expectancy may have improved in Lawndale since 1990, but the life expectancy gap between Chicago's Gold Coast and North Lawndale is a gaping 13 years at the time of this writing. Even with some progress, there is a long way to go. We now have a better understanding of how the social, structural, and political determinants of health and health care, such as institutional racism and poverty, affect illness burden and life expectancy. A plethora of medical and sociological literature published in the last 2 decades gives us greater insights into inequities in healthcare delivery, both how they arise and why they persist. And yet, the interactions described in Mama between the Baines family and the healthcare system in Chicago in 1993 are not very different from those a Lawndale family might experience in 2018. In fact, given recent studies chronicling the unconscious biases held by doctors and nurses that influence clinical outcomes, Abraham's descriptions of the communication gaps and mistrust between the Baines family and their physicians could now be expanded upon with a great deal more evidence. The concepts of unconscious bias and institutional racism and their impacts on health outcomes had not yet been widely researched and disseminated in the early 1990s, but their effects are certainly evident in the experience of the Baines family as they navigated the healthcare system. Abraham describes the racially biased assumptions of the physicians toward the Baineses. She also contextualizes the mistrust the family feels toward the healthcare system in North Lawndale, particularly in light of the Tuskegee syphilis experiment and Robert's own experience with malaria experimentation conducted on Black prisoners in the Illinois prison system. In 2002, almost 10 years after the publication of Mama Might Be Better Off Dead, the Institute of Medicine published Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, which meticulously compared the treatments for Black and other minority patients in the United States with those of white patients and documented racial healthcare inequities for a number of diseases. As we encounter this narrative today, it is worthwhile to consider the concentrated poverty and segregation in North Lawndale, as well as the fragmented and inadequate healthcare delivery system, despite the heroic performance of Mount Sinai Hospital, through the lens of structural violence and structural racism. It is structural because the laws, policies, customs, and procedures that have created segregated poor neighborhoods like North Lawndale have their foundations in the bank and real estate rules that limited Black migration to certain neighborhoods. It is violent because it results in the onset of disease and early death. These historical injustices have perpetuated into the present. Disinvestment over the past 70 years has led to an almost intractable form of concentrated poverty and segregation in neighborhoods like Lawndale across the nation. Social conditions, poor housing, lack of educational opportunities, low-wage jobs, mass incarceration, and inadequate insurance in high-poverty communities contribute to high incidences of illness and premature mortality. Research since the original publication of Mama Might Be Better Off Dead seems to confirm that simply enduring the toxic stress of racism and poverty can also contribute to shortened lifespans. Add to this a healthcare delivery system operating in a state of virtual apartheid, where hospitals like Sinai are kept on life support and unable to offer patients many options for meaningful long-term recovery. And you have a recipe for the transgenerational transmission of poor health. Nevertheless, the reality presented in Abraham's book is neither inevitable nor immutable. As President Barack Obama said in a 2008 speech about race in America, "We are not irrevocably tied to a tragic past." Change is slow, but possible. While the story of the Baines family is a quarter-century old, the neighborhood conditions that spawned the family's despair are ever present. When our nation is willing to rectify the twin evils of racism and poverty, to reinvest in neighborhoods like North Lawndale, and to replace the fragmented multi-payer health insurance that disadvantages the poor with a single-payer system that universally and equitably covers all citizens, it might be possible to read Mama Might Be Better Off Dead as a curious relic of the past. Until then, the book remains pertinent, necessary, and important. David A. Ansel, M.D., M.Ph., Chicago, Illinois. Preface. This book followed the Baines family, Cora Jackson and Tommy Markham, from May 1989 to April 1990. I continued to gather material from their lives and research the book after that time, however, and so much of the data about the institutions or healthcare system is more current. Apart from the epilogue, the only scenes involving the family that took place after spring 1990 are in Chapter 8, chronicling doctor's appointments that I attended with Tommy Markham. The flashbacks to events which occurred before May 1989 are reconstructed from medical records and information the family provided. Scenes in which the family was not involved, such as those that took place in Mount Sinai Hospital's emergency room, happened anywhere between summer 1989 and fall 1991. To protect their privacy, I changed the names of all family members, as well as other patients whose stories I told. The names of all doctors, nurses, and other healthcare professionals are real, except for Dr. Burton Stone, who is discussed in Chapter 13. I interviewed all doctors, nurses, and healthcare experts quoted in this book. Introduction. In the fall of 1991, Harris Wofford, a relatively unknown Democrat from Pennsylvania, won a seat in the U.S. Senate after making sweeping health care reform the centerpiece of his campaign. The victory surprised politicians who had expected his opponent, Richard Thornburgh, the U.S. Attorney General for the first 3 years of the Bush administration, to coast into office. Wofford subsequently became a symbol of Americans' dissatisfaction with the healthcare system and desire for change. A January 1992 survey showed that the public ranked healthcare as one of the top 3 issues the country's leaders needed to address. And 10 months later, Bill Clinton took advantage of that. Campaigning for president on a platform of change, he made fixing the nation's ailing healthcare system one of his top priorities. As of the spring of 1993, it was not clear what shape healthcare reform would take under a Clinton administration, but the new president certainly had no shortage of proposals from which to choose. A 1992 article in the Journal of the American Medical Association summarized just the important health care plans sitting on the nation's plate. There were 41 of them. The millions of uninsured Americans and the spiraling cost of health care received progressively more attention through the last half of the 1980s. But what finally pushed health care reform to the top of the national agenda, many believe, was the discontent of the middle class. Middle-class families with sick children were being priced out of group insurance, even plans offered by large companies. Others were stuck in dead-end jobs because pre-existing medical conditions prevented them from getting insurance from a new employer. And still, others lost medical coverage when they were laid off during the economic recession that began in mid-1990. In some ways, this book has nothing to do with the insurance woes of the middle class. In others, it has everything to do with them. At the book's center are 4 generations of a Black family who live in one of Chicago's poorest neighborhoods called North Lawndale. The grandmother, Cora Jackson, was 69 years old when I first met her in May 1989, and trying to cope with myriad chronic conditions, including high blood pressure and diabetes. She lived with her granddaughter, Jackie Baines, who cared for Mrs. Jackson, as well as her own 3 children and her ailing husband, Robert. His kidneys failed when he was 27, and he then needed dialysis treatments 3 times a week to stay alive. Finally, there is Jackie's father and Mrs. Jackson's son, Tommy Markham, who was only 48 when he was disabled by a stroke caused by uncontrolled high blood pressure. For the past 3 years, I moved in and out of this family's life in an attempt to discover what health care policies crafted in Washington, D.C., or in the state capitol at Springfield looked like when they hit the street. This book provides a qualitative description that is now missing in our understanding of the much-studied problem of lack of access to care. As a reporter who has covered public health first for a socioeconomic medical newspaper and then for an investigative publication focused on race and poverty, I had written repeatedly about the big picture. High infant mortality rates, the surging uninsured population, the scourge of AIDS. Only by following a family for an extended period of time, however, was I able to get beyond the one-time tragedies, an endless flow of health statistics that make the news, and begin to understand the oft-repeated phrase, lack of access to care. It can be a slippery concept to grasp, perhaps because its meaning has been deadened by overuse, but also because, for the poor, it manifests itself in more subtle ways than their being uninsured, ways that are inconceivable to most of us. I came to know Jackie Baines not as a helpless victim, but as a resourceful woman who tried to work the healthcare non-system to the best of her ability. The lengths to which she went to get basic care for her family are one testament to the inadequacy of health care for the poor. The other is that her efforts so often failed. Cradle to grave, this family has been largely left out of a healthcare system that is one of the best in the industrialized world for those who are affluent and well insured, and embarrassingly bad for those who are not. 10, even 5 years ago, those of us in the middle class might have dismissed the poor's struggle to get decent health care as something we could never come close to experiencing. No longer. Most everyone has a relative or friend who is uninsured and crossing her fingers, or who is overwhelmed by huge medical bills or insurance premiums. So far, their hardships may not have approached those the Baines family encountered when they tried to get medical care, but their experience carries a warning for us all. Things will get worse, provided that private insurers continue the trend toward pushing all but the healthiest and wealthiest from their rolls, leaving the rest either uninsured or reliant on what are currently inadequate public programs. But this book was not intended to persuade the middle class that some kind of health care reform is in their personal best interest. Just as doctors use CAT scans and other instruments to uncover disease, this book exposes glaring inequities in healthcare access and quality that exist between the moneyed and the poor. Inequities that existed long before the middle class began to feel the pinch. The place to start is with the uninsured. The poor are more likely to be uninsured than anybody else, and as Tommy Markham said, you could be damn near dying, and the first thing they ask is, do you have insurance? Though his words succinctly express his indignation toward a system based on ability to pay, this book suggests that perhaps the only time the uninsured have a good chance of getting timely, quality care is when they are damn near death. Robert Baines could not get reliable, steady medical coverage until his kidneys failed, and it took a stroke for Tommy Markham to get the same. Neither have held the kind of jobs that provide health insurance, and serious sickness or disability often are the only tickets to government health insurance for poor, single men under 65. During Jackie's first pregnancy, she was uninsured and delayed getting prenatal care for 6 months. When she went to one of the few places where the uninsured are certain to get care, if only after day-long waits, the emergency room of the city's overburdened, underfunded public institution, Cook County Hospital. Though no one would choose to have a baby at Cook County, where pregnant women are herded into narrow stalls like cattle and labor side by side, separated by thin curtains, Jackie was lucky in some ways to have county to go to. Public hospitals in other cities, most notably Philadelphia, recently were forced to shut their doors when government support dried up. Once Jackie gave birth to Robert's daughter, Latrice, she and the little girl were covered by Medicaid, at least as long as Jackie stayed unemployed. Medicaid, the state and federal health care program for the poor, has never lived up to its promise to eliminate the country's two-tiered system of health care. First, Medicaid income restrictions are so tight that the program covers less than half of the poor, defined as those Americans who fall under the federal poverty level. Most of the working poor were and still are excluded from Medicaid, and thus are uninsured, although some of their children are being progressively added to the program under reforms that began in the late 1980s. Those who managed to get Medicaid have struggled to find decent doctors. Medicaid pays physicians well below the rates of commercial insurers, and doctors perceive the poor as difficult patients, sometimes with reason. Poor patients' ailments are made worse by delays in getting care, and they show up at doctors' offices with more of what one physician called sociomass, social problems that range from not having a ride to the doctor's office to drug addiction, to homelessness, to the despair that accompanies miserable life circumstances. As for the physicians who do practice in poor neighborhoods, they may be there only because they are not good enough to work anywhere else. Poor families usually have no way of knowing whether local doctors are up to snuff, even when they have been disciplined by state medical regulators. While Medicaid recipients are exceedingly vulnerable to the vagaries.
Sample complete. Ready to continue?